Good evening, everybody. We'll start in about a minute. We still have people joining. Okay, we'll get going then. Good evening, everybody. Thanks for joining us today. I'm Dennis Grabau with the Johnson & Johnson Institute, and it's a pleasure to welcome you to the second module in our Advanced Posterior Cervical Instructional series. In today's training, we'll start with an overview over radiographic parameters in assessing alignment. Then the majority of the session today will be spent on case discussions, looking at the treatment of various flexible and fixed kyphotic deformities. And if you enjoyed this session today, please join us again for the upcoming modules. We will send the registration details for future events to all of you. We have an amazing, very experienced faculty with us tonight. Our first presenter of the evening is Dr. Hisanori Mihara from Japan. Dr. Mihara is the Chief of Spine Surgery at Yokohama Minami Kyosai Hospital. He's also a counselor of the Japanese Society for Spine Surgery and Related Research. And he is an editorial board member of the Journal of Spinal Disorder and Technique, as well as an editorial member of the Journal of Medical Case Report. Thank you so much for joining, Dr. Mihara. Also, I'd like to welcome Associate Professor Mitchell Hansen from Australia. He is a consultant neurosurgeon at John Hunter Adults, John Hunter Children's, and Newcastle Private Hospitals. And he's been appointed conjoint associate professor in the School of Medicine and Public Health at the University of Newcastle. He has published many articles in various peer-reviewed journals and given many presentations at many international conferences. Thank you very much to both of you for being our faculty on today's training, and also for all your help in creating this module as well as the entire series. Before we get started tonight, just a couple of very quick housekeeping items. First of all, the intention is for these sessions really to be as interactive as possible. So we definitely encourage you to ask many questions. You can submit your questions at any time during the meeting. Just use the Q&A feature at the bottom of your screen. Just type in your question, and then we have allocated a lot of time for our presenters to answer them throughout the meeting. Also, the faculty has built a number of polling questions into some of the presentations tonight. So whenever you see a multiple choice window popping up on your screen, you have about 20 seconds to click your preferred answer. And then the faculty will share with everybody what the trend within the group looks like. And then I have one final request. At the end of today's webinar, you'll be directed to a very short feedback survey, and we'd really appreciate it if you could take a minute to share your opinion on today's event on there. And just let us know how we can make these sessions even more impactful and more valuable to you. With that, we'll get started with the scientific program. To kick things off, Associate Professor Hansen will be asking a number of polling questions on your clinical background. First of all, that allows us to test the polling feature, but it also gives the faculty a much better understanding of the level that the audience is at today. Thank you very much again for joining, and over to you, Prof. Hansen.
Thanks, Dennis. Welcome to everybody. Speaking to Dennis earlier this evening, before we got on, he said that there's 9 different countries involved tonight. So it's quite exciting to be involved in this. And I'd like to thank Deformities for putting this on. Obviously, travel's a bit awkward at the moment, but we'll do the best that we can. Just a few questions to start with. We're wondering if you could fill them out. The poll should have popped up on your screen. If you could answer these, it'll just give us a bit more feedback to be able to pitch things to you. So I'll give you 10 or so seconds. Okay, Dennis, next question. Okay, so that's good. So the next question we've got is just how many years out of practice you are, or how long outside of specialty training you are, if you could answer this. Okay. So it's a great mix of people that we've got tonight. Did everybody get this, Dennis?
Yes, everybody can see this.
Yeah, great. So you can see that we've got a very good mix of people here. And then we'll have the final question to see whether you're on the dark side or whether you're neurosurgeons. So whether you're a neurosurgeon or an orthopedic surgeon. Should be enough. 2/3 to 1/3. I'm not really surprised. It's reflected in which country you work in as to how many. I know that China, very much, most spine surgery is done by orthopedic surgeons, and it varies elsewhere. So that's interesting. Thanks for doing that. When I prepared my talk today, I was interested to see how the parameters for cervical deformity, the papers that have been published, have really exponentially increased in the last few years. So I'm very excited to hear Dr. Mihara's talk this evening on the parameters within cervical deformity. So we'll move on to Mihara-san. Arigato.
Thank you, Professor Hansen, for organizing this seminar. And thank you, everybody, for joining this seminar. My name is Mihara from Yokohama, Japan. Today, I want to talk about radiographic parameters in cervical deformity. When we saw such a patient with cervical deformity, we used to look at XP, CT, and MRI of cervical spine and discuss how should we treat this patient. However, after Dr. Schwab published the theory of spinal harmony, we need to have wider views for cervical deformity. Before his publication, I already noticed that C7 location and its inclination were key parameters for considering cervical alignment related to global spinal alignment. We published this theory in Japanese textbook in 2012. However, nobody cited my theory because the book was written only in Japanese. In this textbook, I drew the vertical axis line from the midpoint of the anterior and posterior arch of the atlas. I believe this line is more important than C2 prime line. So in the textbook, I also introduced two models of cervical spine construction. One was a model stacked from below, and the other was fitting from above. Whichever, we always need to recognize that cervical alignment has strong interaction to the lower spinal alignment. However, please remember the role of the cervical spine in supporting head gravity. Most doctors believe the COG of the head locates at the ear canal. There was a report which precisely calculated it using 3D analysis in cadavers and found that the COG located slightly ahead of the canal. However, the difference was very small. Then I think we can use the ear canal as a reference point of COG. But please use a clear lateral view to visualize the ear canal. I don't know if he knew it or not when Dr. Ames introduced his concept for comprehensive assessment in cervical deformity classification. He did not use COG, but used C2 and C7 prime lines as reference lines of cervical spine. In any case, this paper affected lots of spine surgeons in the world. Then let me introduce their concept. His team classified cervical deformity into 5 types. First, C-type has an apex in cervical spine. CT-type has it at the cervicothoracic junction. T-type has a primary sagittal deformity apex in thoracic spine. Some doctors put forward by dividing upper and lower thoracic spines. S-type means the primary deformity is in coronal plane. And CVJ type has main deformity at the craniovertebral junction. Ames also advocated 5 modifiers as follows. C2, C7 SVA indicated distance between C2 and C7 prime lines. CBVA means chin-brow vertical angle, which directly reflects severity of drop hand deformity. TS-CL means mismatching between T1 slope and cervical lordosis. He suggested this value should be 15 degrees or less. Myelopathy is also picked up by using MJOS score. In addition, SRS Schwab classification is included as HIFS modifiers. This paper written by Frank Schwab is very famous, and please remember the key parameters such as PI minus LL, SVA, and pelvic tilt. To summarize the statements of Ames' paper, cervical sagittal alignment is related to thoracolumbar spine pelvic alignment. Then cervical deformity should be evaluated with global spinal alignment. They found that C2-C7 SVA has correlation with general health scores and myelopathy severity. Therefore, when performing cervical decompression surgeries, we need to consider the sagittal imbalance when present. Let me explain about relation between cervical spine deformity and total spine alignment. Dr. Mizutani explained global spinal alignment in cervical kyphotic deformity through the point of compensatory mechanism. He divided cervical kyphotic deformity into head balanced type and trunk balanced type by presence or absence of compensation by the thoracolumbar spine. In short, head balance type was compensated by backward shift of C7SVA, and trunk balance type was not compensated. Let's confirm key parameters in his paper, such as vertebral slope, C2C7 SVA, or C2C7 lordosis, and C2C7 SVA, COG C7 SVA, C7 plumb line, it means C7S1 SVA, PI minus LL, and PT. We need to remember these parameters for discussing cervical or spinal deformity. Several papers introduced standard values of such parameters. T1 slope should be 25 to 40 degrees. Cervical lordosis requires 31 to 40 degrees. Then TS minus CL will be less than 20 degrees. C2, C7 SVA has less than 40 millimeter. COZ C7 SVA has less than 30 millimeter. And Chimbro angle less than 11 degrees, and so on. Using such indicators, we should consider surgical strategy for cervical spine deformity. For example, when we see patients suffering from drop head syndrome, we should classify the pathogenesis of the deformity. CT localized type is relatively simple because the pathology is located to the cervical spine or CT junction. This type usually shows T1 slope less than 25 degrees and SVA less than 40 millimeter. However, when we encounter a patient classified as full spine type, we need to look at the commonly shown T1, look at the general condition. This type commonly shows T1 slope more than 40 degrees and C7S1 SVA more than 40 millimeter. These are example cases treated by us in my hospital. Left case was a medical doctor suffering from drop end syndrome classified as CT localized type. And right case was an RA patient who had received several surgeries. Her drop head syndrome was classified as full spine type. We also need to consider the flexibility of the deformity. For fixed type, dissociation or osteotomy will be required, followed by rigid fixation. For flexible type, less invasive surgery can be planned. At the surgery, we should set the goals of these parameters. Key points are C2, C7 SVA less than 40 millimeter, TS minus CL as 20 degrees or less, C7 S1 SVA less than 40 millimeter. Other treatment for CT localized type DHS, we just focus on T1 slope and cervical lordosis. Then surgical range would be limited in cervical or upper thoracic spine. However, for full spine type, we need to consider the correction and fixation down to lower thoracic. Otherwise, we should plan a correction surgery for thoracolumbar spine at first. Then left side case was treated by C2 T1 posterior fixation, and he returned to his job as a medical doctor. Right side patient required long fusion from occiput to Teha 12. Still, she needs to support for standing, but she can keep horizontal gaze in sitting position. I want to summarize the talk. First, cervical sagittal alignment is related to total spinal alignment. Second, regional cervical and total spinal alignment should be evaluated preoperatively for appropriate operating planning. Third, C2 C7 SVA, T1 slope minus CL, and C7 S1 SVA are important parameters for surgical goal setting. Thank you for your attention. If somebody has a question, please ask me.
That was a fantastic talk. How do you best work out your overall balance? Do you use an EOS scanner, for example, or 3-foot films? What's your best way of doing that?
I think, yeah, EOS is a wonderful item, but my hospital doesn't have EOS. But so only the standing film. But of course, we need to a view with the total spine included. It's very important. Possibly, so from the head to the side or knee.
Do you think that if you're only using a 3-foot film, for example, would you do that seated, or would you do that standing?
Standing is ideal, but at the right side case I showed, so the patient hardly holds the standing position for 1 minute or 2 minutes. So in such case, we need to take X-ray in a sitting position. But ideally, we should take in a standing position.
Yes, I guess there's a concept that in this day and age, most workers, office workers and the like, are actually spending 60% of their time seated.
Okay,
and so that's coming into the lumbar parameters now for sagittal balance. Do you think that concept is one that you might consider?
Yeah, it's a very interesting idea. You know, in the recent office, as you mentioned, many workers are in a sitting position. You're right, but sometimes they need to walk, stand to go to toilet or somewhere. Yeah. So basically, for human being, the standing and walking is very important function. So we always consider such standing position postures. But of course, depending on the patient condition, in the future, we look at the sitting position posture, important.
Yeah. We have a question from Dr. George. How about the decision for approach for the correction, anterior or posterior or both? How do you decide?
In a second, after this lecture, we will show some case discussion. Probably, yeah, we can answer for questions, so case by case. But you know, for the very fixed type, we need to perform the both procedures, not only the front but also the back side. But depends on the patient condition. After this, seminar lecture, probably my case and Dr. Hansen's case will help such example. All right.
Okay. If there aren't any more questions, then we might move on to your your case presentation, Professor Mihara.
Okay. Let me just a second, please. I changed my slide. Can you see my slide? No?
Not yet.
Not yet? Okay. Let me check. Okay.
Okay.
Can I see? Can you
Yes,
see?
perfect.
Okay. So today I took a case with cervical deformity for discussion. This case was okay. Oh, I'm sorry. Just a second. Sorry. So this case was 62 years old woman with arthroid cerebral palsy. She was born with premature cardiac telos. Her vertex index indicated feeding with half assist and gait with a cane. 9 years ago, she complained numbness on the 4 extremities. 1 year ago, she became easy to fall and showed a drop head, and then a physical disability center consulted us. She had a numbness, muscle weakness on all extremities, particularly on the left upper extremity. She could not walk at admission. Deep tendon reflexes were hyper, and sensory disturbance was spread under cervical spine. She showed severe drop head and could not see ahead at all. Chimbro angle was 85 degrees. T1 slope as 36 degrees. C2, C7 lordosis as minus 65 degrees. C2, C7 SVA as 87 millimeter, and COZ C7 SVA as 126 millimeter were all significantly abnormal. We could not measure C7S1 SVA, PI, PT, or LR because she could not keep standing. We could measure T1 slope as 36 degrees in sitting position. Her cervical lordosis, minus 60 degrees in neutral position, was decreased to minus 82 degrees by flexion and was increased to minus 20 degrees by traction and extension. Myelogram showed cold compression lesions at C34 and C56. C56 disc was collapsed and slipping. The severe kyphosis was found to be flexible. According to an algorithm provided by Ham, we have three methods as follows. Anterior decompression and fusion, including segmental ACDF or corpectomy. Posterior method was also a candidate for surgical treatment, but we need to decide the UIV and LIV properly. The other choice was combined method. Okay, please consider your surgical plan.
Okay, another 5 seconds to vote.
Okay. Most surgeons select front back, anterior and posterior. Okay. Yeah, next question. What is your upper instrumented vertebra, UIV? Please select. Okay. Most doctors consider C2 should be the UIV, and 34% select the occiput as UIV. Okay, thank you. And how about the next question, please? What is your lower instrumented vertebra, LIV? How far should we choose? Upper thoracic, wow. Very good, very smart surgeons we have today. Okay, may I advance my case discussion? Okay. So our choice was combined anterior and posterior fusion, as most doctors select.
Dr. Mihara, you're in presenter mode now.
Excuse me?
You're in presenter mode now.
Yeah.
Oh, we see both of your notes in this slide.
Nobody, you cannot see?
Yeah, we can see your notes.
Okay, let me check. How about this?
We can still see the notes.
Okay.
Sorry.
How about this?
It's not showing up yet.
Oh, okay. Let's back to the, this slide. How about this? Can you see? No?
Not yet.
Not yet. Okay. Oh. How about this slide? Can you see?
Yes.
Okay.
Okay, this is perfect.
Okay. All right. Our choice was combined anterior and posterior fusion. At first, we performed the posterior interspinous fixation using wavy rod system, which is a kind of semi-rigid fixation. On the same day, we did anterior segmental decompression and fusion at C34, C45, and C56 using box cage and decorative plate system. This is a picture after the surgery. This surgery required 292 minutes and blood loss was very small, 80 milliliter. So very short fusion we selected. So we achieved good alignment immediately after surgery. However, C6-7 segment showed focal kyphotic change 1 month after the surgery. C2-C7 lordosis decreased to -20 degrees. Then we put a halo vest for 3 weeks. After halo vest removal, she discharged. We have been observing the progress of the kyphotic change. It has been advancing slowly and her T1 slope became 40 degrees. So TS minus CL became 47.8 degrees as a final follow-up. So far, she doesn't show ADL worsening, but I think we should extend LIV on T1 or lower as the initial surgery. So to summarize the experience of this case, segmental front back fusion was most secure surgical method for flexible cervical spine deformity. We achieved good posture by front back fusion within cervical levels, but careful post-operative management was required for the patient with involuntary neck motion. Longer fixation involving T1 or lower thoracic was desirable when predicting the decreased compensatory effect with aging. Thank you for your attention.
Once again, I think that was a fantastic talk. Thank you, Mihara-san. We'll start with the first question from the audience.
Yeah.
Why posterior first in that case?
Okay. So before surgery, we confirmed this deformity is flexible. Then I always consider when we correct the deformity, we should use the human body as a spinous process. When we keep the spinous process, much easier to correct the deformity. That's why I select the posterior first by closing the interspinous space and hold some instrument, and then we go to the front and segment by segment fixation we did. Much safer and easier correction, I believe. But of course, we can use this technique in a flexible case. That's my idea to do the interspinous fixation to correct the deformity.
Mm-hmm. You used a myelogram in that case. Is that standard, or was there a reason they couldn't have an MRI?
She had involuntary neck motion that we could not take MRI because she cannot hold the same position posture. And on the myelogram, of course, yeah, we can hold the patient and we can take standing myelogram. But it's not pure standing films because we need to hold her.
So we have another question from the audience. It's a flexible deformity. Is only posterior an option by going from C2 to T2 with pedicle screws?
Yeah, that's another idea, I think. But you know, many doctors already experienced the instrument failures in a patient with atherosclerotic cerebral palsy. The patient showed involuntary neck motion immediately after the surgery. Even if we perform the posterior fixation using pedicle screw systems, so many cases show the instrument failures, including the screw breakage or rod broken. So I don't think the only posterior fixation is not reliable. So I recommend front back fusion. Of course, yeah, we can use posterior fixation, but at least we should do anterior fixation in the same day.
You said you put them in an orthosis for 4 weeks post-surgery. Is that your standard?
Yeah.
And how did they go because of the athertosis?
Of course, athertos motion continue. So, yep. But you know, Botox sometimes help the degree of involuntary motion. Botox is a kind of botulinous toxin. It's the kind of injection decreases the muscle contraction power, but by surgery, we cannot control such involuntary motion. So we need to consider such motion would continue for her life.
Yeah, I must admit, I don't normally put somebody in any orthosis after a fusion unless their bone quality is so poor and perhaps I've augmented, but I don't generally put them in orthoses afterwards. That'd be something interesting, Dennis, if we could ask that question to see how many people use an orthosis after cervical fusion surgery. If we can put that maybe towards the end in the Q&A. When you measured the center of gravity with this dropped head, did you use the ear canal or the true center of gravity that you showed in the first lecture? Just because whilst it doesn't make much difference when the head is where it should be, when it's right down, there's actually probably a couple of centimeters difference between those two positions, I would think, for center of gravity SVA.
Yeah. So yeah, yeah, you're right. But so that
splitting hairs, it probably doesn't matter too much when they're awful like that. But I'd just be interested to know.
Yeah, yeah. But I don't have a good answer. But that one reason MS use the C2, C7 pram line. So to discuss on the cervical deformity, sometimes it's very difficult to consider the COG as a reference point.
Yes.
Mm.
And if you go back now to do further surgery in that patient, where would your upper instrumented level be, your lower instrumented level be, and would you use a titanium rod or a cobalt chrome rod?
I prefer the titanium rod. Cobalt chrome rod is too stiff. So I don't think, titanium is better. But sometimes to decide the UIB and LIB, it's very difficult. It depends on the case, condition, age, and general condition. So many factors will affect the decision. But at least, I think, shorter fusion is better. But many doctors select the longer fusion. But if possible, we should select the shorter fusion, particularly if the patient shows such involuntary motion. That's my opinion.
Yeah, I think I would agree with you. It doesn't look like we've got any more questions from the audience. Okay. If it's all right with you, Mahara-san, I might move on to mine and we can come back to more questions at the end. Maybe people will warm up a little by then.
Okay. So let's move to the case section discussion from Professor Hansen. Are you ready to present the next case?
Yes.
Okay, let's start, please.
Okay. Thanks once again to Depew for organising this session. I saw the last one and I think it went very well. Hopefully people are being quite informed so far. I've been tasked to look at a fixed deformity, and this is a patient of mine that I operated on last month. So I won't run over this again because I think Mahara-san's done a fantastic job of explaining the parameters that we look at when we go to look at surgery. But as you can tell on this case that I was looking at, we're looking at a more localized phenomenon rather than one that is globally affected. So there's a number of different approaches that we can take to the spine to try and fix a fixed kyphosis, or a mobile one for that matter. But these different osteotomies, both anterior and posterior, were summed up quite well in how to approach the cervical spine. So as you can see, there's a number of different options for you within our armamentarium. They range from an anterior cervical osteotomy to open up the fixed deformity, to different posterior ones, including Smith-Peat osteotomies, pedicle subtraction osteotomies, and then anterior posterior osteotomies. As you can see from this table, there's a number of options here, and the amount of correction is the interesting thing here that we can see, where a pedicle subtraction osteotomy, which is a posterior operation, you can get a very large mean angular correction. A front back might give you less so, but I guess it depends on the size of the osteotomy that you're doing. This article from a Chinese group looked at the different Smith-Peet osteotomies, and basically this, gives you an idea of how to perform these, where you can just do small drilling out of the facet joints here, but there's still some facet joint, which doesn't give you a great correction. The Smith-Peet osteotomy, which can give you a larger correction, or you can go up to a full pedicle subtraction osteotomy, which gives you a much larger amount of correction. So back to my case. So this was a 27-year-old male who in November last year presented with a C6-7 osteomyelitis. He required ICU admission and ventilation. Staph aureus sepsis was found secondary to intravenous drug use, and he was very, very unwell. In those first few days in intensive care, it wasn't expected that he'd actually survive. He was initially treated as he improved with flucloxacillin when the sensitivities came back, and I elected to place him in a hard collar for treatment as he had no deficit, and this was his imaging. So as you can see, he'd already developed some kyphosis, collapse within the disc space, and already some movement translation there. That said, looking at his MRI, he had quite a lot of prevertebral phlegmon that I thought would make surgery difficult. As I said, he was quite unwell, so a surgical option really wasn't there for the first several days. He did have phlegmon behind the vertebral bodies, but as you can see, there was no signal change within his cord. And neurologically, as I said, he had no signs of myelopathy. So he did well and left hospital. I elected to keep him in the hard collar, which we removed at 3 months as he had no instability. We continued to follow him up as he was young, and I thought that he would come into trouble. And at 9 months post-presentation, he developed a Lemitz phenomena and brisk reflexes. He still had no signal change within his cord. And then at this stage, it's when elected to look at surgery, as he was no longer using intravenous drugs, apparently. So this was his MRI 6 months post-presentation. We can see that the signal change from the active infection had gone. There was a bit of change within the vertebral bodies, but still there was no signal change within the cord. Here's his CT scan. I think this was 7 months post presentation. We can see that he's obviously fused at the C6-7 level, which I find happens most of the time. He did have indentation of the spinal cord, but importantly to look at, he'd fused his facet joints on both sides. So that made me consider different ways to approach this spine. Part of the pre-op workup obviously is a CT angiogram to look at the vasculature. Pre-operatively, I haven't done as nice a job as Professor Mihara, but his C2 plumb line was 35.9 millimeters in front of his C7, and there was 24 degrees of kyphosis C2 to C7. So to consider the surgical procedure, we've got a number of options. We've got anterior, posterior, anterior, posterior, posterior, anterior, posterior. I guess I could have gone anterior, posterior, anterior, but I'd like to survey the audience to see which way they might have gone. Dennis, that should be long enough. Bit of a mix. It's always a way when we ask spine surgeons what they're going to do, I think, how they're going to approach. And it's also what you're more comfortable with. So I might show you what I did, and then I'll ask Mihara-san to let me know what he might have done. So I guess for me, it was the facet joints at the back as well as the anterior fusion. So this is obviously fixed, but fixed posteriorly as well as anteriorly. So this, the approach I took was a posterior, anterior, posterior approach. From the posterior, I basically did pontiosteotomies at the back with laminectomy, which we can see in this grade 2. Once again, Chris Ames published this article. And so I went posteriorly and did formal C6-7 laminectomy with pontiosteotomies at 5, 6 and 6, 7. This I thought, as there was, I was concerned there might have been some ligamental buckling at the back as I straightened this up. It also gave me a bit more room as he was very tight with that anterior, when I was drilling out the anterior portion, that I perhaps might have some space by decompressing at the back. And then also I thought that I would need, as he was fixed posteriorly, in order to get any correction, and I thought that I'd get most of it from the front, that I'd need some space at the back to be able to do that, obviously. So I did these Smith-Peets and then skeletalized the bone-ins around the vertebral arteries. I then came from the front, and it's a little bit difficult to kind of follow the Ames et al. Form here, where yes, I did a complete corpectomy at C6 and C7 from the front, but I did take it out to the transverse foramen, so I guess this kind of became a grade 4 as opposed to a straight grade 3, where I could get out and then, you know, had the vertebral arteries on show. So positioning, I used a Jackson table with the patient in the Mayfield clamp to be able to maneuver this once I'd done some releases. So posteriorly, my approach was, as I said, Smith-Peet osteotomies, so that I'd try and get a larger correction when I came back to the back. So this is following the Smith-Peet osteotomies. And you can see that bit of C5 spinous process is intact, but 6, 7 and down to T1 are gone, and there's not much left in the facet joints. But we're still fixed at the front, so obviously I had no correction there. So then I'd flip the patient and did an anterior approach to the C6-7, and then undertook the corpectomy, as I said, to include the foramen and the uncovertebral joints, because this is where I thought I'd get most of my correction. So this X-ray was done partway through. The vertebrectomy at the front. And then, as you can see, after completing the anterior corpectomy and the osteotomy, got a significant improvement in the sagittal balance. This was done just by winding up the patient on the Jackson table. I then placed an anterior strut with the DePuy Bengal stackable carbon cage. I like that because there's not so much flare on imaging post-operatively. And because I was going into where there'd been previous infection, I used a silicon-based graft material rather than standard fibre stuff. So even with just the anterior approach, you can see the change in the plumb line from the pre-operatively to the post-operatively, and I was very happy with what I'd done here. Patient was then flipped back, and then I went a little bit longer as this patient I don't think could be trusted to keep with a short fusion, and went from C2 to T2 using the new Symphony system from DePuy, which I had pedicle screws at C2, T1 and T2 with lateral mass screws from C3 to 5. The purchase I got with the screws was fantastic, and then I was very happy to lock that off. So as you can see, I got a much improved lordosis as opposed to a kyphosis with this correction. So take-home messages, I guess. I think the baseline T1 slope minus the cervical lordosis, if it's greater than 17, is probably the greatest indicator of ongoing neck pain and problems for me. That said, you do need to consider the whole spine and approach, but certainly in this patient who's 27, otherwise normal, that wasn't such an issue. As you could see from earlier slide, there's a number of ways to rectify a fixed cervical deformity, whether it's anteriorly, posteriorly, or combined. You need to have all in your armamentarium to individualize care, because I think, as Mahara-san said, really it's individual approach for each patient that comes. And so therefore one method does not fit all circumstances. Thank you very much. This is Newcastle, where I'm from.
Oh,
So.
thank you, Professor Hansen. Wonderful job you did.
Thank you, Mahara-san.
Yeah, great. So I got one question first already. So the question from maybe from Japan, he asked you about if the patient have disability of finger movement, do you perform operation area? Do the patient have some symptoms, neurological symptoms?
Yes, certainly. If the patient had neurological symptoms, once they were over their septic incident, so if they'd presented with neurological symptoms, then I would have done the surgery from the start. I've unfortunately had to deal with quite a few patients that have had intravenous drug use and have active infection there. And I find that you still got to treat them. And certainly if there's neurology there, I will look at doing a procedure from the start. I might temporize things and just do like for example, with that case, I probably would have done the corpectomy first to decompress the spine, and then did a 2-level corpectomy with that patient. I still would have used a silicon-based graft material. I find that fantastic. I've not actually had to take anybody back to debride the wound that I've done that in, and I've had some pretty ugly infections. But I would have put that patient in a collar with that, with just the anterior approach, with the view that I might be coming back once the infection had settled to perhaps do something posteriorly as well.
Okay. I understand. Maybe the audience will recognize. Okay, so I have some.
Can I ask how you would have done that case?
Excuse me, sorry.
How would you have approached that case?
Oh, so same way. First, I will perform Smith-Peterson from posterior and go to the anterior. Probably I perform C6-7 corpectomy as you did. And finally, I will instrument from posterior. But probably I will use C4 or C5 pedicle screw to shorten the fusion segment. But we need to, fuse down to T2 as you did. Yeah, maybe we need 2 anchors, upper and lowers.